issue attention to bowel management. There were a couple of questions early on that were slipped into the bladder conversation that have gone into the answered section of our questions. I'll put them out there, whether we answer them now or not. So one was a question about whether it was true that support workers from providers funded by NDIS are no longer permitted to complete enemas, and it is now to be completed by RN or EN. How can we change this NDIS issue? So that was one question, and then the other one was a question about a stimulation program that was trialled some time ago. I think they were the two key ones. Pete, can you remember if there was another one that we...
No, I think that's about it. Yeah.
Okay, so one is about the stimulation program that was trialled some time ago, and the other is about whether NDIS providers can perform complete enemas, or whether it has to be done by a registered nurse or enrolled nurse.
I'd like to throw this to Anna. What your thoughts are on fleet?
Well, fleet enema is a completely different enema to just the microlax or the duralax or bisalax as it's known as. A fleet enema has more volume, and it also is a completely different chemical irritant, I suppose, to the other two, which are micro enemas. So just having said that, a micro enema compared to a large fleet enema, which is often used as a preparation for, you know, a colonoscopy or a bowel prep or something like that, obviously using that with its different, and I honestly can't tell you what's in it because we use them so rarely, but it has a lot of different electrolytes in it, and using that on a regular basis, in my opinion, would be quite problematic, put it that way, that there would be loss of electrolytes and things like that through just the fact that they're a very harsh enema. So I would use them for bowel prep or if someone was severely constipated, but a fleet enema wouldn't be something that I would use on a regular basis for those reasons.
In some hospitals, it is a practice I've heard, not in the Austin, but it is a practice that I've heard some patients, that's the way that they come onto a ward and they get cleaned out. And in this particular hospital, it does tend to, I hear it through patients that continue with fleet, but you've answered it really well. That's very harsh on the bowels and bladder management. And
it could be used just as a one-off, Pete, but to use it every day would, to me, be concerning. So, yeah.
And what was the other one?
Okay, far away. Question? And it was to do with actually whether it can be given by support workers or by a nurse. And that's probably, in essence, exactly what the issue is. That one is, it's got lots of chemical irritants, and it is a, when I say dangerous, I don't want to use that word, but I want to use a word that suggests that it probably should be given by somebody who has a knowledge behind that, rather than a support worker who is giving something that is fairly innocuous and is just used as a trigger to start somebody's bowel action off. So they're given for different reasons, in my opinion.
I think that question more had to do with, you know, disability support workers.
That's right.
Sort of changing, if they're allowed. Yeah, I don't know what the answer to that is.
And different agencies would actually have different policies on that as well. So if the particular agency that the question came from are not happy to give those enemas, then they have to actually work with the agency, I think, or the person has to work with the agency to find out why and what the issues are behind that. Yeah. So, and nurses don't, it's not common that nurses actually do bowel care for any of our spinal patients either, which is another common misnomer as well. People do think that nurses do bowel care. They don't. In probably 95% of cases, bowel care is done by support workers. So if that is an issue for this particular person, then they it perhaps needs to be investigated with their agency.
Yeah, that's maybe another question. If they want to contact us, we can sort of follow that up as well. So, I mean, so if we move on to bowels, which we have already, but it's sort of similar in a way to bladder, you know. I mean, when our routine isn't right and we have accidents sort of at unexpected times, it changes what we want to do. You know, I mean, we're motivated to go out and do something, and if we have an accident along the way, that stops us in the future of, you know, trying to go away and organise stuff, and just for any reasons, even going to a restaurant, you know, something like that. So I know for myself, over the years, my management has improved. You work out what works for you better and not. I remember in rehab, I trialled going every morning and then going every second day and even going every third day, and trialling different things like laxatives 12 hours before my bowel routine, and that seemed to work for me. And you change it around a little bit, you know, I was able to fine tune it. But again, over the years too, your body changes as well. And I'm constantly trying to find out better ways of make my routine work for myself. And I'll go into, you know, how my routine has changed over the years as well, but just wanted to see what people have done. You know, have you found that your routine has changed over time, or did you work out, you know, if you go out somewhere and you have an accident, like a bowel accident, what do you do? You know, I mean, do you prepare yourself in a different way that you would to a normal day? Like, for example, people travelling overseas, they might, instead of going every morning, you've got no choice, you know, you've got to go every second daily, especially if you're going overseas on a long distance trip. Does anyone want to start talking about that?
I don't mind sharing my bowel routine. I'm a second daily type, and have my bowel routine every second morning. I just prefer to do mornings. It starts my day off. I know some people, through their lifestyle, like to do it an evening, but I don't mind getting up, having a shower, and getting up a bit earlier, doing my bowel routine. I've found the best thing that works for me is routine. So if I just stick to a routine, and everybody will have a routine, that the consistency is the biggest part that your bowel likes. So I'm consistent. I take my medication about 10 to 12 hours prior, the day before, and everything seems to go okay. Of course, sometimes between like hot and cold weather, you know, I might get a bit constipated. You have to tweak things a little bit, drink more water. Sometimes I get too hot at night in bed because I can't take my blankets off. So, you know, those things you're aware of, what dries you out or what constipates you, but you just have to sort of really listen to your body and see what that is. And that consistency thing really is important. But it's something I've heard a lot over the years with a lot of my friends and clients who, with the bowel management, is just get consistent to some sort of a pattern and stick to it, and it settles into that pattern. Yeah.
Can I back that up, Naz? Just on the points of routine, that's absolutely critical. And one thing about being in a routine is the body doesn't know weekends. And I know that some people start a really bad habit, not doing bowels on weekends or when there's an important day coming ahead. I think it's a really bad habit to get into. You just get in the habit of getting up earlier and doing your bowels on a day as best as possible, because your bowel knows the routine is just every 48 hours becomes a pattern. The other thing about routine I just want to say before I go is it's not just your bowels, it's your eating. Your eating should be pretty, you can't help sometimes you go out and have a big meal on a birthday or something, but try and keep your eating routine about the same thing. Snacking, having a meal one day at 12 o'clock and one day at 7. Try and make that, and that becomes a thing, you know, if you get used to it, it doesn't become too much. I always, and I'm quite sure there's quite a few people here, we always eat at night time, roughly about the same time. And that works really well because then you build that routine that Peter was talking about.
Yeah.
Yeah, no, that's very true, Murray. Well, what about being adventurous like you were? I think it's good that, I think Kath mentioned, you know, you've got to enjoy life as well. So you can try different things as well, but be conscious of, you know, what could happen as well. So if you're going to try things, the way I look at it is try it, but don't go too crazy with it.
Yeah. And for me too, I found that don't make any drastic changes quickly. It's something you got to do slowly and give time to, like not a day or two, probably a week or more, you know, that you change your routine and do things. Myself, when I first had my spinal cord injury, the first few years, I put a lot of pressure on myself around my bowel routine. And I used to stress a lot about my bowel routine. And I think I made it a lot worse. Well, I did. I made it a lot worse until I relaxed and got that in control. I didn't worry about it and just took it as it came. You know, then it was my bowel routine settled down a lot. Yeah, I used to do a fair bit of anal stimulation too in my bowel routine. You know, so my bowel got used to doing that, which was a bad thing because it had a lot of associated problems, hemorrhoids and stuff like that. So I went away from that, try and do as much as I possibly can myself. And that's worked better. So I've sort of retrained my bowel routine in that aspect, Nas. Yeah, not to have as much stimulation. Yeah.
No, that's a good point. And you know, trying to start a new routine as well. I mean, I take Seneca, for example, 3, sometimes 4, 12 hours before I go. And that changes up and down over the years. I know a lot of people would have tried different things as well. So how do people prepare? You know, do you take laxatives beforehand or not at all? Or did you and you stopped?
Is that my question or everyone's?
No, that's pretty much out there to everybody.
Yeah.
Well, except Anna and Kath, of course.
That's okay. I can answer if you like.
Yes. So what have you seen, Anna, over the years, and what seems to work better? And also another thing that I want to make sure that we compare as well. Is there a relationship to the bowel and the bladder?
Well, Kath mentioned before that there are some issues to do with leakage in especially people who have suprapubic catheters or urethral catheters, or even for that matter, people doing intermittent catheters. If they have a large bowel that's constipated, that is going to push pressure onto their bladder as well. So there is a correlation there between them. And if someone has a urinary tract infection, that might affect their bowel habits as well. That might actually mean that they are slightly constipated, or they may go the opposite way if they're taking antibiotics and things. So there are some relationships that we can correlate, I suppose. But I think the points that you and Pete made are so important that, you know, the bowel is a creature of habit. And if you all understand that the habit is the one that you make and the one that suits you and your lifestyle, then I think that's really important. And it might have to suit if you go to work, or it might have to suit if you, you know, like going out for meals of an evening. So you may do your bowels at whatever time of day that suits you, but also keeping in mind what perhaps was your habit before your spinal cord injury. Some of you may not remember that, but some people new to it may actually remember that, you know, their bowel habit was first thing in the morning after they had a cup of coffee. And so that is important to try and mimic those sorts of things so that you're not fighting against your body habits, I suppose, as well. Yeah, so you know, whether you go every day or every second day is, again, a choice that you can make as well. And my only correlation there would be that if people are having problems with their bowels, they're either constipated or they're having accidents, that a daily routine might actually help to sort things out and then relook at the program as well if you want to go back onto a second daily routine. So it really is an individual thing, like a lot of things about spinal cord injury. What suits one person doesn't necessarily suit the next, and you have to work out for yourself what's going to work for you.
A question that's popped up here is Seneca. Yep. Now myself, I've been quadriplegic for 21 years, so probably the first 10 years I took 4 Senecot every second day, and with also Metamucil as a bowel softener. And then after 15 years, I jumped up, but now currently I'm on 6 Senecot the day, every second day, the day before my bowel routine. But the question is, how many Senecot is safe, and is there too much or too less?
Yeah, and that is a question I get asked a lot, and I get asked it by people who take 1 or 2, and I just go, that's a drop in the ocean. I would say the average dose amongst my spinal cord community is probably 8 tablets. The average dose is 8 tablets. And I'm not advocating that you need to take that many. But some people do. But if you're taking 12 or 14, and lucky the people who are taking those are not on the chat list here today because they know who they are, that to me is far too many. That is far too many. And obviously they're not working. And so you need to think about trying something else that might actually be a pusher or a stimulant that's going to do the same as the Senecot or enhance the action of the Senecot as well. So pushes are important.
Can you talk a little bit about that? The difference, because I take Coloxal as a softener and Senecot as a pusher. Yeah, and that's really good point. Some people don't know the difference, or just talk about that. Yeah.
Absolutely, that's a really critical point, that people understand what they're taking and what the action of it is. For instance, Senecot is a pusher. Duralax or Bisalax or Ducalax tablets, no, I'm not talking about the enema or the supps, are actually a pusher as well, a very strong chemical stimulant. Senecot is a mild dose, but Sena also comes, as someone's pointed out to me recently, comes in other doses, like the Ford Sena actually is double the dose of the normal Senecot. So the tablets that you take in that needs to vary according to the dosage, I suppose, within the tablet itself. Coloxal is a softener, and Coloxal is used to get the right consistency of the faeces. So, you know, I've got my bowel chart here, so I thought I'd just show it to you all, because, you know, that's my bowel chart. So to get the right...
That'd be good to share if we can't really share that on screen.
Oh, but I can send you a copy, or do you want a copy, you know? You'll find one on the but no, that's share. I can give you a copy afterwards and we can share it. But having an idea of this consistency, people think, oh, you know, here she goes again. But it is important because you can troubleshoot from all of that. You can troubleshoot from, you know, whether you actually have soft faeces, and then you need to know that you need to add, you don't need more Coloxal, you need a bulking agent of some sort. So Coloxal is a softener, and the misnomer about Coloxal is that Coloxal can be taken or should be taken at least twice a day, if not 3 times a day, even if you do your bowels every second day, because Coloxal works on the food bulk and draws in the fluid as it makes its way around the colon. So, you know, Coloxal comes in 2 different dosages as well. Coloxal with Sena is not my favourite, and that's partly because it's a pusher and a softener together. And so trying to actually differentiate between whether you need more softeners or more pushers is sometimes difficult. So I'd rather separate them out and be able to increase one or the other, or decrease them according to what you need. A lot of people, there's a lot of other aperients out there. Movicol seems to be a favourite of GPs, and I keep telling people I wonder if GPs have got a share in the company, because I'm not a fan of Movicol. I think in small doses it can be useful to get the right consistency, and that on my little chart again is type 3 or type 4, so one of these here, so soft formed. But it's not, oh, thanks, Kath.
Oh, excellent.
So it's type 3 or type 4 is what we're aiming for. And
the job of Movicol, Anna, is?
The Movicol is an osmotic laxative. So it actually is a pusher, but it also draws in fluid as it makes its way around the colon. The trouble with Movicol is often that it's prescribed too often, as in sometimes doctors or GPs recommend that it's taken twice a day doesn't need to be taken that often, in my opinion, because it acts as a pusher, and so therefore your timing is all out. If you take it morning and night, you're probably more likely to have bowel actions morning and night, and that's not what most people want. It also sucks in or draws in air into the gut, and so a lot of you who actually have bloating or that uncomfortable feeling that your gut's distended is often caused by osmotic laxatives like that, and like lactulose and Actilax and whatever is a lot of people use it and are fans of it in small doses. It works in some people. In other people, it causes lots of issues with gas and bloating in their gut. They're probably the most common appearance. Nulax is still used by a lot of old timers, and Nulax is nice. It's got a lot of different things in it. It's got senna, it's got treacle or something like that in it too. So, but it's also got some other natural fruit to dried fruit and stuff as well. So a lot of people have great success with that. So there's a lot of different appearances.
I found the fibre drinks really help me a lot too, like help me lower my medication a bit. Fibre drinks pull in the bulk and help the push too. Yeah. So
okay. So what do you use, Pete? Metamucil or fibre gel or?
Metamucil.
Yep. Okay. Okay. So Metamucil and Fiber Gel are great as a supplement for fibre. And that's a really important thing that people need to get in their diet. And if you can get enough fibre in your diet, but that is consistent with the amount of fluid that you drink, then that's how you get the right consistency of your faeces. So, lovely topic, isn't it? But that type 3 to 4 is what we aim for. But in someone who goes every second day, type 2 or type 3 might actually be acceptable. It's more the soft. I love the way Kath keeps coming back here. She's not. The really soft feces like type 5. Oh, that's Sal, is it? Oh, okay. 5, 6 or 7 are really are too soft, and people may find that those ones, thank you, Sal, I feel like you're the barrel girl or something or other now. 5, 6 or 7 can mean that it's really soft and difficult to know if you're empty or not. So if you get more up further, then you've got a greater chance of knowing the amount that's there and the consistency is what's normal for you. So yeah, for me, fibre can be used, but don't be misled, I suppose, by how much fibre you need. If you don't drink enough, then adding fibre to it will actually not necessarily help hard stools, for instance. In fact, it probably will cause them to be firmer, in fact, as well. So just be aware of what the fibre does as well.
And are we aiming for type 4, which was there? Quite a lot.
Yeah, 3 or 4.
3 or 4, okay.
3 or 4. I'd even accept type 2, but that just depends on people. Preference as well. Type 5, 6 or 7 to me are far too soft and unpredictable.
I use on a once a week sort of basis. I use the anal peristine.
Yep. Yeah. Great. Yep.
I find that gives me, especially so I do a lot of activities, Spartan races. So anything, if I've got something big, like sporting wise on that day, or even if I've got a wedding on, if I've got something that's important. Yeah, I'll definitely use the peristine the morning of, and I find that it gives me a thing for like 2 days. So the next morning I find it struggle to go, which if there's a little bit that comes out, then I know that it's all good. That's the first thing. Second thing, so I use the glycerol and the Dulcolax suppositories with 4 Senocot and 2 Coloxyl, like I said the night before, and I use supps in the morning. Is that too much? And can you use supps for too long? It's working.
Both. Yep.
I go every morning. I don't have accidents. I'll probably have an accident now, but I said that.
Of course you will. You've mozzed yourself.
Yeah.
Suppositories and the difference between suppositories and enemas is also important to understand. So a suppository, for all of you who know about it, is a solidified bullet, I suppose, that is made up of either a glycerin, which is just a glycerol or a lubricant, glycerin, or a Duralax or a Bisalax is actually made up of a chemical irritant. So depending on what one you use, you may actually have different effects, and it may actually also have different effects on your bowel. Now, some people have been using Duralax suppositories or Duralax enemas for years and have no problems or no issues. So what I say to people, whatever works, that's fine. If you are getting symptoms like mucus from your bowel or bleeding, or they're complications that maybe need to be investigated, and why you're getting that. Is it due to the chemical irritant in the Duralax? Maybe, maybe not. It might be due to other techniques that you use as well. So there's a lot of variables, and I think understanding using one of each was what we always did in years gone by, a glycerin and a Duralax. I don't know whether that's as useful, and most people tell me now that they just use one sup, and so they just use a chemical irritant, the Duralax, and they have success with that. If they don't, then try something different. Try the glycerin rather, which might be more gentle. It has an osmotic effect, so it might have a drawing effect. Likewise, does the Microlax enema have a different effect altogether to the Duralax enema or the Bisalax enema. The Bisalax is an irritant, whereas the Microlax is more of a drawing or an osmotic effect as well. So depending on what your bowel is, as in whether it has activity, reflex activity, then one or the other can be used. So it is having an understanding of how your bowel works, I suppose.
How do you work that out, Anna? I mean, you know, it's not something, where you try suppositories for a once-off or a week and see how that goes, and change to Bisalax and then to Microlax. How do you work out what? The
most common way of working it out is to know whether you have tone in your rectum. And if you've got tone, that is that you've got, clamping on your finger when you put your finger into your rectum, that means that you would use something like you could use either a Duralax or a glycerin suppository. Likewise, you could use a Duralax enema, but a Microlax probably is for someone more so who doesn't have that reflex activity, which is strong. Some people lose it over time, and don't ask me why that happens. Maybe it is, again, overuse or overstimulation. Pete mentioned that before, that, we used a lot of stim, or did you say that, Naz? One of you said that a lot of stim was used and you don't use as much anymore. And that can actually weaken or tire, I suppose, the anal sphincter as well. Likewise, people who do manual evacuations, that actually weakens or when I say weaken, it weakens the sphincter so that it's not as tight as it used to be as well. So there's a lot of different reasons why people would use different triggers to assist with emptying.
What is it, manual?
And the peristhene, a manual? Is that what you mean by a manual evacuation?
Yes.
A manual evacuation is when you don't just do stimulation. That is, stim to me is just putting your finger into the first knuckle joint, and either gently, I'll use Ash, for those of you who know Ash, who's a nurse on spinal rehab, he taught me this. So you put your finger in and just gently relax the sphincter. I don't know whether you can see it as well there, that way, that would gently relax the sphincter, or just a gentle circulation as well, or gentle, circular motion. Whereas a manual evacuation is putting your finger in and scooping out what is actually in the lower bowel as well. So they're very different techniques, and some people use manual evacuations very successfully. And in fact, in overseas bowel routines and stuff, that is the management of choice for all paraplegics, for instance. They who can do their own bowel care, they would all do manual evacuations. We don't teach it as much because I feel there are other options that we can use as well. So, and the fact that we want carers to be able to assist with care, manual evacuations are usually not permitted by support workers. So that's something to keep in mind.
That just made me think, Anna. So does it matter like where your lesion is to what's going to be, pretty much what's more effective? So if you're a quad or a para from T1 to T6, for example, or L1, is there like some sort of a guide for what should be working better for you?
Yep, there is. Yep, and it's the same, much the same with your bladder, but bowel I think is even more important. So someone who has reflex activity usually has what we call an injury contained in the cord. So that means that it's above the level of the bottom of the cord, which is about L1, T12 L1, and above have what we call an upper motor neurone lesion or a spastic lesion. Reflexes are used as the activity of the bowel to assist with emptying. Whereas those with an injury below that, or the chordae equina, that horse's tail at the end of the spinal cord, those reflex activities don't go back into the cord at the level below the spinal cord injury. And so they don't have as active reflex activity as someone who has a higher injury. So definitely all the higher paras and quads will actually have reflex activity.
Can I just say something quickly? If people get totally sick of the whole bowel routine, which I did after about 6 years, and I had all sorts of problems with hemorrhoids and then subsequent hyperreflexia, I bit the bullet and said, right, that's it. I can't take this anymore. I'm going to have a colostomy procedure.
Colostomy.
And that's made my life 100% so much easier. And,
Jeff, I'm going to remember you as one of my peer talkers then, because I am now a big fan of people actually making that choice as well. And it is a choice that you can make if bowel routines are becoming laborious, that they're actually taking hours out of your day, then I think that people should consider that. Or what Lenny mentioned before, and I'll show you that, the transanal irrigation, if people are interested in that as well. But colostomies are great.
That's becoming more and more common, and I've sort of seen more and more people taking that up. So again, just quickly, why would someone go that way after seeing that, whatever they've tried isn't working for them, and then that's like a last thing that they try. Is that how it works?
Yep. It is and it isn't, Naz, because I suppose I want it to be an individual choice. I want people to be able to make the choice that their bowel routine is difficult, that it's taking too long. Anything over an hour to an hour and a half to me is far too long, and I don't know why people would want to sit on the toilet that long, because there's other complications like pressure injuries and hemorrhoids, and the last thing people want is accidents and for their bowel routine to become so complicated. So if you've got all the above happening, then I think a colostomy is a good choice for you. They're more readily available now. I would say 10 years ago we only thought about colostomies in people who actually had major bowel issues, and sometimes it's too late, because the bowel may actually, and I noticed there was a question about megacolon, it may have developed this large colon, and so that makes it a little bit more difficult to have a colostomy, because there's two different types of stomas. There's an ileostomy, which is small bowel, which means that it's liquid and it requires emptying more frequently. So the bag might need to be emptied 2 or 3 times a day, whereas the colostomy is the large bowel, and that's formed, so it comes at the end of the bowel, so it's formed, and that probably only needs to be emptied daily. Or there's some clever people, one person who's actually on the chat who actually does a washout of their colostomy on a regular basis, and that he doesn't wear a bag at all. So there's a lot of different options available now that I think even 5 years ago were not available to people.
Yeah. So just with the washout, what is that? I've just never heard that before, Anna. I'm just thinking other people might know more about that.
Yep. So Lenny mentioned it, and it's known, there's a couple of things. It's known as transanal irrigation, and what it is it irrigates into the bowel by a system. And this, you can imagine, well, I'll show it up here, but this is what the contraption looks like.
More and more of that too.
Yeah, so this is actually a contraption that has a pump on it, and you pump water that sits into a bottle like this. Sorry, I'm trying to show it on the screen here, but it sits into a bottle, and you pump the water via a catheter like this. Okay, I've got the wrong end on here. Yeah. Anyway, it pumps into a catheter like this that inflates a balloon, and the balloon then sits into the rectum, and water is irrigated into the colon. So that means that there's a volume of water, and again, depending on how often you use it or how sensitive your bowel is, you will use between maybe 500 or 600 mils. Lenny, I don't know how much you use, but
700, yeah.
How much do you use? 700, yeah. So the volume varies according to the person and how often you use the technique as well. This is by Coloplast, and it's known as the Peristine, but there is another one made by, they used to be called Wellspec, but I don't know what their new name is, and that's known as the Navina. They're still Wellspec, don't they, Kath? Okay, and that's called Navina. And then there's another one that is made by Seiko, or actually I don't know that they actually use that as well, which is another one that has a small pump type thing known as the Kafora. And that's just a small little pump, and you can see there what it looks like with a little.
Your volume.
I'm sure you've broken up for me, Anna, but pretty much we can see there's a few companies that have similar systems, and it's just a matter of finding out who's doing it, who's making it, and even asking questions of some of the guys that have got spinal cord injury as well. I know this is becoming more and more popular over the past few years. I've been seeing more and more people using it, so it is a good option for people. Yeah, it's just a quick and easy way of people, who don't want to be sitting over the loo for, 2-3 hours each time. And the results I've heard have been pretty positive. I mean, you can get it done within half an hour, and you can get going, and the amount of accidents has reduced as well.
Yeah. Hey, question to Jeff. Jeff, is there any negatives around the stoma bag, colostomy bag?
Not really. I'm just looking at a question by Colin about bowel flatulence. I get a fair bit of flatulence as well because I had a lot of fruit and veggies. And just to let you know, Colin, that colostomy bag has, well, at least the ones that I use, but I imagine all of them have a charcoal filter so that it filters out the gas and it doesn't smell. Yeah, it can make a bit of a noise, but you usually don't smell it unless the bag's got blown up, and then you might need to change it or stick a pin in the filter or something like that. And but yeah.
And having a suprapubic catheter and a colostomy bag, is there any chance of cross-contaminating, or is it something you really have to maintain and look after?
At first I used to take the bag off when I was showering and just wash it all around in the shower, which I found caused infections because obviously some would get into the suprapubic area. So I wouldn't recommend that. But I mean, colostomy bags are waterproof. So you can have a shower and you can have it on. Sometimes I'll just stick a plastic bag roughly sort of around it just to keep the worst of the water off, so it doesn't affect where it sticks. Yeah. Some people have ones that clip onto a permanent sticky thing on their skin. Mine, I just have ones that stick to the skin, and when you need to change it, you just peel it off, clean the stoma and around the skin, and then you just stick a new one on. Use a hairdryer to dry it all out. It's
So
pretty
all
easy.
good, Jeff. I
Takes-
mean, it's just made you so much more independent and having less to worry about, you know, your routine and going out and all that sort of stuff.
Yeah, I mean, I need somebody to change it for me. So as long as somebody's around who knows how to do it, or you can talk someone through it, but preferably somebody who knows how to do it well. It takes about 5 minutes, and it's so much easier than sitting on the shower chair for hours on end and having problems with dysreflexia and so on. And I don't have to take any of those chemical, you know, stimulants.
Tablets or anything? Yep.
Yeah, I take Nulax, and you know, I try to eat fermented things like sauerkraut or fermented veggies and things like that, which give you a good gut health, and they seem to help as well. And I don't really have much problem at all. It doesn't really matter if it's a bit soft, because you just change the bag and there you go.
Yeah. Hey, Anna, can I bring that back to you? Is there any negatives in health or absorbing minerals or anything around that with colostomy or elostomy bags? Yeah.
You mean as in absorption and
Yeah.
stuff like that? Is that what you mean? Yeah.
Yeah, I'm just thinking of any negatives. Yeah. I just want to educate myself.
Yeah, some negatives. I usually go through this with the stomal therapist when one of my patients is looking at having a colostomy, and they're great with it. They will give you just a bit of an overview, but sometimes there are certain foods that they will tell you to avoid, and you may already know this, Jeff, but things like nuts are something that they tell you to avoid unless you've chewed them down, because they can get caught in the stoma area as well. But I don't know there's many raisins or I think it was raisins, is that right? Or grapes or something like that was another thing that I think one of the stomal therapists mentioned to me that can become a problem, because they swell up and can cause that blockage in the stoma itself as well. The other thing that is, and Jeff may want to comment on this, is that the bowel is tied off and pulled out, I suppose, into the skin level here. That's what the colostomy, how it's formed, but it's called an end loop, and in fact there's still some of it that can, some feces that can still go down past that stoma. And so a lot of people will actually do once a month, or however often, just have an enema in their rectum or a sup or something like that, just to empty whatever has bypassed and gone past, to empty out their bowel. But they're the only precautionary things that people tell me that they need to use. The aesthetic look of it is something that a lot of people don't like, the actual having a bag and having what they perceive as the smell. And believe me, most of the bags now have, you know, a valve in them, and there's charcoal and all sorts of things where you can't detect any smell. But some people actually have an issue with that, and so, again, may choose to use a different system. As I said before, the bowel washout type issue through the stoma is what a couple of my patients use as well.
Yeah, I saw that.
So I'm learning all the time too.
I saw somebody said that they do an irrigation. Personally, I can't see the point personally of having an irrigation. I just change the bag if it needs changing.
Changing, yeah.
The irrigation is just basically taking up time that I would rather not waste. And the best thing about the colostomy is that, you know, I used to have to, I was ruled by the 2 days, every 2 days I'd have the bowel care. Whereas the colostomy, you don't have to worry about any of that. And you can go away, you don't need to take a commode chair.
Commode chair, yeah.
You can just have a couple of spare bags and some wipes in your backpack. You can go out anywhere, and as long as you, like for me, I have to have somebody who can change it, but you just go into a disabled toilet somewhere and change it. Takes you 5 minutes, and then you're off to do the next thing. And you just have to be careful you don't let it get too full, because sometimes the stoma just wants to empty out a whole lot all at once, and if you let it get too full, then it can blow up, and you get a mess if you don't change it in a timely manner.
Back to the question.
But and the other thing is, I was going to say, with the I do get, it didn't happen for a couple of years, but now probably about every once a year, the anus decides that it's got a build-up of mucus, which was, I think it just naturally keeps creating mucus because it thinks it still has
In the bowel.
to lubricate for bowel movements. But after about a year, I get a bit of dysreflexia for a day or so and don't know what's going on, and then suddenly all this mucus decides to come out, and it's pretty unpleasant when it happens. It only lasts for a day and then it's gone. One product use.
That's what I mentioned about the maintenance stuff, Jeff, that some of my patients tell me that a maintenance thing is that every couple of months they would actually give an enema or a clean out to make sure that they remove that mucus as well.
That would be an option, yeah.
Someone's mentioned that the bowel is removed. In fact, it's rare that the rectum is actually removed. There's an end loop that is made to pull the bowel out, but the rectum is still there. So in some people, that's the case. It depends on, in some people, when it's done for other purposes, as in cancer, then they may remove the whole rectum as well. It is different.
That just leads me to another question there. And Jeff, I've heard when people get a colostomy, a lot of people, most people are really happy when they go that way, but is it something that's reversible too?
Some of them are. Some, yeah. But not all.
Yep. It does depend on what procedure they actually do. So, and an ileostomy, which is the small bowel, is probably more difficult to actually reverse than what a colostomy is. Yeah. Yep.
It's 30. We've just gone 4:30. I don't know if we can keep people much longer, but we've got 15 unanswered questions. So I'm going to set you the challenge of answering them in 25 words or less.
There's one here, and I think it's a good valid question. It's around hemorrhoids, and give us a rundown how to deal with them, and also is surgery recommended? Yeah.
Okay.
Well, I think, so I just want to, before you answer that, and I just want to say it's probably pretty common. I've had them over the years as well. Is it something to be scared of as well? Of course, it depends on how bad they are. Just want to go into that.
Yeah, I suppose hemorrhoids are one of those sorts of things that we try and avoid, and it's one of the major complications along with constipation. So hemorrhoids can be avoided, and I'm going to say, or we can do things to lessen the occurrence of them. And a couple of simple things are the size of the commode seat, believe it or not, is actually, or the hole in the commode seat, make a big difference. If you've got a large hole and your bum is pushed down into it, you're more likely to actually have more pressure on your rectum, and therefore hemorrhoids will form. Believe it or not, a simple thing. The other thing is, how much anal stim do you have? Or do you actually give an enema on the commode? And people go, I've always done that. And I go, well, that could be a contributing factor to hemorrhoids. Or fissures within the rectum as well, just simply because of the nature of the hard enema. Anal stim, too much anal stim might cause bleeding, but it might also cause the hemorrhoids to form. And so if you do have a lot of bleeding, then that can be the dangerous, I suppose, side of it. And some people can lose enough blood via their hemorrhoids that they require, major interventions like blood transfusions and things as well. So avoiding the hemorrhoids getting really big is probably one of the important things. So to minimise what people are doing if there are hemorrhoids there. And hemorrhoids are treatable. You can use ointments, creams, cold compresses on them, but once you've got hemorrhoids, unfortunately they are something that probably, and if they're large and bleed a lot, that they do need to be operated on. Simple operation is banding, so they band them a bit like what's it called when you do that with a with sheep, you know, what is it called? Yeah, anyway. Yes.
This is a,
That's what they would do with banding. Banding them and they fall off, or it can be a surgical operation. So depending on what the surgeon sees or what he suggests is necessary, that's how they'll manage it.
They staple it.
But, you know, they can staple them, but again, depending on how large they are, Josh, and how big they are, the banding is more common and they prefer that because it's a fairly straightforward procedure. If they're external hemorrhoids, that's relatively easy. If they're internal hemorrhoids, then there's usually an operative procedure to excise them that's necessary as well. So that was part one of the question. What was part two of the question?
No, you
Naz?
covered
Was
everything.
that it?
That's good.
just having a look. Yeah, that pretty much answered it. Thanks, Anna. Just trying to see what other questions have come through. I'm just looking at.
I can see a couple here that I might answer. Yep.
Yeah, if you can, Anna, that'd be good.
Which ones go, Anna? You choose.
Well, I don't know that I can actually, but apparently the end, I don't know that I need to actually answer that. Apparently the end of the large bowel is removed, but I think I've already answered that, saying that it's not always removed. There is, the rectum is usually still there. I eat anything all good, and I know who that is. Well done. But the underpad, I'll just see whether I can, so I don't have anything off the top of my head, but we'll see whether we can find something.
Yeah, I'm sure there's like so many different types out there, but there's got to be one that's more suitable than others, especially for people sitting down, you know, around the clock in a wheelchair.
Anything that's got a charcoal in it, because the charcoal absorbs stuff, so that may actually be one of the ways, I suppose, of managing it. What are you doing there, Naz?
Sorry,
Hand up.
I've got an iPad. Yeah, I've got an iPad, and the buttons are close to the camera. So sorry about that.
That's all right. You're probably trying to put your hand up over my face. I know. Okay. Were there any other questions? But just to reiterate, bowels, individual, you know, routines, understanding what your bowel, what medications that you're using, and sticking to a routine are the most important things. You know, the consistency of the feces as well as the consistency of your routine hopefully will help you avoid accidents, because accidents must be one of the, and it is in lots of research and literature that's been published, bowel goes up to about 80% of people's biggest fears who have spinal cord injuries. They just don't want to have bowel accidents, and I get that. So we need to actually work on those sorts of things with people, and knowing how to troubleshoot. Troubleshooting your routines and understanding what you're taking and the purpose of them is really important too.
Anna, there's a question here. Someone has cauda equina syndrome. What's best for me? I'm struggling.
Yeah. Yep. Cauda equina is a difficult one because it's not, they have a flaccid lesion, and so usually a microlax enema is best, but sometimes going twice a day is what's necessary in people who have that large bowel and a lax sphincter as well. If that person is someone that I can chat to, then I'm happy to help as well. But it is that they're usually a lot more difficult to get a set routine than some of the upper motor neuron injuries or high spastic reflex injuries.
So if people patients of the Austin, they can get to you via the clinic, the Metro Clinic, yeah?
Yes, they can, yep. And I'll give you my email, or you can give my email address. Where do I need to type that? You know what it is, those?
Do it in the chat, yeah, I'll do that for you.
Okay. Yep. So if you want to put in my email address, I'm happy to address any other questions that people have individually. Yep, for sure.
All right. There was just another one. It's gone. away. There was,
I eat anything. That's good.
I do too.
Do you? So you don't avoid anything like the grapes or the peanuts?
Um,
The stomal therapist often will tell me that.
I mean, I don't eat a lot of peanuts anyway, but I mean,
Yep.
I have cashews,
Yep.
and macadamias, and I'm not a big grape eater, but I'll eat them. And but I mean, I try to keep fairly healthy as well. I try to avoid food.
And it's more about eating them whole, I think, more than anything might be the cause of the blockage. And I doubt anyone swallows a peanut whole.
I think if you chew your food and drink plenty of water and you know, take a natural something that's natural.
Diet. Yep. Diet and fluid are really very important, Jeff, and I can't stress that enough either, that a lot of people can get off their medications completely if they actually have a good diet with fibre in the diet and enough fluid as well. Yep, for sure.
Yeah, the only medication I take is Hyperreflexia for the bladder. I don't have anything else other than herbal supplements and things.
Great. I like to hear that.
Great. It looks like some of the panelists have been answering some of the questions online also. So
good.
I feel like at a glance and without keeping people for too much longer, we may have covered most of it. Let's reiterate. Kath has shared her email on the chat, kath.byrne with a Y. BYRNE at austin.org.au, and I've just shared Anna's email, anna.brown@austin.org.au. So you can email them directly. If all else fails, you'll get a message tomorrow thanking you for your participation today, and you can email those questions through to me and I'll pass them on to Kath and Anna. It's been a big session.
It has.
It was going to be 2 hours, and I think we broke on our online session, which went for 2.25 hours. Yeah, I think we're just about to hit the 2 hours.
Okay, good.
Hanging around. We've had quite a few attendees stick around, so it's obviously a question of a topic that's very important to people.
Yeah, definitely.
Wrap it up.
So I just want to say before we finish up then, does anyone want to add any advice for others out there that they found what works for them better if they're stuck? For me, for example, I mean, I take Senecot 12 hours before, and my routine is at night. I change from going during the day, morning, because I just want to get up and get going. You know, I don't want to sort of muck around in the mornings. I'm not a morning type of person, but I find if I don't take my Senecot, it takes me a lot longer, and that could be psychologically as well. If you know you haven't taken or done something, it could play on your mind and make your body react in a negative way as well.
Yeah, Naz, I'd like to just echo Anna's points there, saying that you can, move to a way of just eating food, eating healthy with water. And I guess that's a journey that I've got to and able to do without any medication or any of that sort of thing. And I think a tip early on, the mind can cause, a lot of tricks in us and a bit of anxiety. So I think very early on, I kept a bit of a food diary. So like people have mentioned over this journey, like maybe what you eat, the amount of water intake, and then, after a while, it just becomes second nature and you're able to do what you do with a really good routine. Mario, you had a question or a comment?
Yeah, so just two things. One is about, I don't take any tablets at all. And I'm also a bit of a perfect asshole in that I don't have much in the way of hemorrhoids or anything. And
I'm glad to hear that.
The reason I bring it up is because of two important things. One is, obviously, when I'm looking at me, I eat a lot of curry. And I think that you don't need Senecot if you do have stimulation. Because I'm not kidding, seriously. Food that stimulates Senecot, all it does is stimulate your colon. And spices and chili do exactly the same thing. So that's one thing. And the second and the most important thing, the only thing I want to any other panelists that's helped me all these years is I don't use anal stimulation. I use water stimulation. So I move I don't pull the shower chair fully back on the toilet, and I get my carrier to irrigate my bottom with warm water, and that's all the stimulation I've used for the last 20 years. Which
I've heard that helps as well.
Absolutely, every single time.
Right.
Yeah.
So would you recommend the Vindaloo or what?
All of that.
Nas, wrap it up. Wrap it up.
Mild, medium, or hot.
Yeah, rice,
Getting
bananas,
low.
and the odd stir fry. Yeah.
And you go daily, Mario, or
No,
second
twice
day?
a day. Once every second day. Sorry.
Every second day, yeah.
On Thursday day, and I've not had
Yeah.
Senocot or anything like that for about 18 years. Yeah.
Nice.
Great.
Okay.
I love hearing
What
that.
about
Yeah.
anyone else want to add anything before we finish up today? All good? All right. Excellent. Thanks very much. So you can thank everyone and let them know what's going to happen after this. Going to go online. This video is going to go online in a couple of days. And if anyone's got questions that they didn't want to ask or they forgot, they can get in touch. They've got our details.
Yep. I think we'll be releasing it as a two-parter.
Was it
The
that
video.
long?
Did you say Pata or?
And if anybody wants to ask any questions, then I think I can speak on behalf of the other mentors that we're all happy to email or chat online or over the phone if people just want to speak person to person.
Yeah.
Definitely.
Nice work.
Our details can be got from Sal. No trouble.
Yep.
Okay, excellent.
Thank you, everybody. Thank you. Big thank you to Kath and Anna for joining us today. And during the internet problems of the Austin Health, it's been dropped
Austin Holter, yeah. Sorry.
afternoon. And thank you to our panelists, Mario and Jeff, who've lasted the distance, Julie and Lenny. Thank you to our peer support team, Josh, Lynn and Peter, and our leader, Naz, team leader, Naz. Thank you all for your knowledge and information and sharing today.
Good one.
Down.
Thank
What a
everyone.
nightmare.
Thanks, Bill.
See you guys.
See you later.
Thank you.